Good afternoon, everybody, and appreciate the opportunity to present. Thanks to the RAFT chair and co-chairs, Matt and Denise, for terrific presentations. And these talks came about as kind of a poll or inquiries from the SAGES community. So these were kind of education topics that we heard the membership wanted to hear more about. And so they're kind of disparate topics, but hopefully, of some utility. It's great to see so many people here interested in education. And I think it's because of the topic, although I've learned if you put the word luncheon in the title of any talk, it brings in an audience. But if you do that, you have to serve food. So just a tip. And by the way, this talk is about EPAs, and this was something that we heard, again, from the membership. There was a lot of confusion about, and relatively new topic. I should clarify, we are talking about entrustable professional activities. There is another EPA that's been in the press recently. That's not what we're talking about today. That's Scott Pruitt and other stuff. So entrustable professional activities, we're not talking about the other EPA. Quick show of hands, how many people have heard of EPAs? Okay, good. How many people feel like they understand what EPAs are about? Yeah, and I think that's also kind of the general sentiment is this is an emerging or evolving topic. So nothing to disclose. We're going to start by talking about EPAs and defining what they are, using them to assess trainees, and then I'm going to briefly introduce kind of something coming down the road, which is an EPA pilot that's being conducted nationally that I think will be very interesting and a lot of us will have a lot of involvement in. So first we're going to talk about some definitions, and these are a number of topics or terms that have been thrown around throughout the last 15 years. And so I thought it'd be worth just defining a few of these. This is from a WMC article by Dr. Englander, who's a pediatrician, but has spent a lot of time working on this and developing the National EPA project. And he's kind of spent some time defining these terms. So competencies is something we've heard about for a long time. This is really more of a goal or an objective, or I think the other two terms are more assessment pieces, but a competency is roughly a goal. Something that we observe from a health professional related to a specific activity that includes knowledge, skills, attitudes, and values. A milestone is then a very specific, defined, observable metric or marker of a trainee's ability along a developmental curriculum. And we'll come back to that in more detail. But a milestone is an assessment. A competency is really a goal. Now, another assessment is EPAs, and this is what's been coming more in the lexicon more recently. And we'll talk about this in more detail. But it basically is, as Dr. Englander described, an essential task of a discipline, and that's where the surgery specialty training comes in place, that a learner can be trusted to perform without direct supervision, and a clinician entering practice can perform unsupervised in a given context. So again, the term entrustable comes in place here. So just looking back a little bit, the ACGME competencies, believe it or not, are almost 20 years old now. It started out in 1999. It came about through a collaboration between the ACGME and the ABMS to establish the 6 core competencies. And depending where you look, the AAMC has kind of expanded it to 8, but I think most of us still use the 6 core competencies. And the idea was, before medical education training was process-oriented. You put somebody in school, medical school for 4 years. At the other end, they come out with an MD. You put somebody in residency for 5+ years, they become a general surgery trainee or a general surgeon. But really to try to shift that paradigm to look at outcomes. And the competencies came about as a result of that. So we all know, very familiar, the 6 core competencies. It's been in our, again, lexicon for many, many years now. But how do we assess the competencies? And this is where I think we've been spending more time now. The competencies are great. We have, our curricula designed around the 6 competencies, but now how do we have the rubber meet the road? How do we assess them? And so now here's where the milestones came in. And the milestones is a relatively new concept, and so worth talking about that as well too. for those that have been involved in residency training, especially in the clinical competency committees or CCCs, are very well attuned to this. But the idea is to assess the different competencies, but to do it in a developmental fashion. That is, we're not just interested in the end result. What does a medical student look like at the end of 4 years? What does a resident look like at the end of 5 years? But is it important to track them as they go along? What should a first-year resident look like? What should a second year, third, fourth, and fifth year? And so the milestones were meant to really look at this in a kind of granular fashion along the 6 domains of the competencies. And this is now broken down by specialties, as we know. So every specialty has their competency and every subspecialty too. So not only are there general surgery milestones, but also urology, colorectal, both for residents and for fellows. Any ACGME approved training program has milestones that have been developed. And it's meant to be developmental. So ideally, trainees, although they may have ups and downs, are meant to progress along the milestones. And now the ACGME has, now that this has been out a few years, has hordes of data and tens of thousands of data points of trainees as they've been evaluated by their respective clinical competency committees, put this information in the national ACGME database. And they're now being able to collect, and people can track where they are according to their respective peers, both nationally and locally, with regard to the milestones. So this is all well and good, and we've got our competencies, we've got milestones. It sounds great. So what's the problem? Well, a lot of folks have commented about the years. Are we artificially slicing and dicing this too much? Is this really become too granular? And if you think about it, when we evaluate a trainee, we don't really, look at somebody and just focus on their medical knowledge or their systems-based practice. So, is this too granular? And this is where the EPAs, really came about. The competency has been described as not really kind of the lens by which we really observe our learners in a real practical setting. When we measure competencies, again, is it really too granular? Is it too sliced and diced? And again, when you think about what's a competent medical student, a competent resident, a competent practicing physician, we really don't look at them by their 6 competencies. You look at the whole package, right? You look at them as everything being put together in a synthetic way. So, for example, we take it a case of a resident being able to do a thorough evaluation of a new patient who they're seeing in, as an inpatient consult or in the emergency department. How do we evaluate that resident? How have we been doing that to date? How many of you have evaluation forms that you have to fill out online, New Innovations or one of these guys, that are broken down by the 6 ACGME competencies? Yeah, almost all of us have it. It's basically become a requirement now by our RCs and so forth. But how many of us, when we go to sit down and evaluate a trainee, we're thinking, well, okay, I guess how's their medical knowledge and how is that separate from the patient care skills and so forth? Isn't it really about the whole package, and how are they performing in a real clinical environment? So thus led to the idea behind EPAs, and this is not initially specific to surgery, but we'll come back to how it relates to surgery. So really the core, in my opinion, is that EPAs, or entrustable professional activities, come back to be a practical framework for the assessment of the competencies. The competencies aren't going away. I think they're important. I think they've stood the test of time. But competencies really focus on a single domain, a single ability, whereas EPAs focus on the integration of the competencies that we all really need to deliver appropriate care. And so, how do we bring this concept of entrustment to the workplace? And, this also came about as a result of the ACGME in 2011 having an increased focus on direct and indirect supervision. And this also came about as a result of the duty hours. So we all know our residents went from unlimited duty hours training to 80 hours a week. And as a result, we all had to become much more efficient and specific about the training. No longer was education by accident a sufficient model. We had to think very intently about education, or education by intention. And so we also had to make sure that our trainees hit the ground running when they start, that they are, when do we know that they can be switched from direct supervision to indirect supervision? So a lot of this also generated the EPA concepts. And this is a kind of a schematic that comes from the AAMC, and it's worth spending a little time reviewing. So the way that they've kind of described this is an EPA is meant to encompass a number of domains, and the domains are the 6 ACGME competencies. So if you think back to an example of somebody evaluating a new patient in clinic, or a new patient in the emergency room, you know, the EPA is the being able to assess a new patient. The domains of competence are patient care, medical knowledge, communication skills, and so forth. These are the sub-competencies. So within patient care, for the milestones, you know, we all have these sub-competencies about the technical aspects of patient care, you know, and with systems-based practice, ordering tests cost effectively, and so forth. And then the milestones are meant to basically break each of these up into their components, where early milestones are beginning level performance, and end stage milestones are what's expected of the finishing trainee. So this is kind of the conceptual framework for EPAs and how it fits into competencies and the milestones as well. And so again, these are not anything that, you know, one's going away. These are not inseparable. They go hand in hand. I think, you know, one way to look at it is competencies and milestones are really a granular approach. They're really looking at the finite kind of specific activity or the objective, whereas the EPAs are really the, you know, holistic approach, or the big picture, if you will. How do we put all this together, and how do we look at our trainees when all of this is synthesized? You know, a good new patient consult, it's insufficient if they know the patient's, you know, differential to the 26th, you know, degree, but they can't communicate with the patient effectively, or they can't strategize how to order the tests in the emergency room. So it really is about the whole package. So, you know, the EPAs, the goal again is really assessment, and to be in distinction to competencies, which I think about more as objectives, but really to develop an assessment framework that allows trust to be granted to complete the core activities of a general surgeon without supervision, right? That's what we all want. By the time our trainees graduate, we hope, we expect, if we've done a good job, if they've done a good job, that they can practice independently, and that we're comfortable, you know, signing off on them, saying that they can do so. We want to reduce the variability of our trainees. And just to keep in mind, these are not really meant to be kind of, you know, expert level, master level performance. This is kind of a common set of, you know, core criteria, or a floor, not a ceiling, by which all trainees should meet. Now, how about for surgery? And surgery is particularly interesting, and I think in some ways more natural for EPAs, and in some ways more challenging. So obviously, think about what's the bulk of what our trainees do, what we do as surgeons. A lot of it is you know, hands-on technical performance and operative performance. There's a lot more to that, obviously, but that's a big part of it. So how does that look like for modern surgical training? It's, again, about, you know, partnership between the learner and the evaluator, the surgeon and the trainee. How do we trust them? What we do in some ways, obviously all of medicine is critical, but how do we trust them from the first intern when we hand over that scalpel and we want them to make the incision straight? When we hand over the robot to the person doing the first, you know, robot colectomy, that, you know, we know that they know how to operate the thing and which pedal does what, and they're not going to collide into some organ. How do we feel like they're ready to take a junior resident through a lap chole while we're standing in the back of the room kind of watching intently and patiently? All of these are key questions that I think surgeons have to face that we don't necessarily have in other specialties or in a different way. The other thing about it is, nobody's getting, I've never heard anybody say, my schedule's gotten lighter and lighter over the years, that I'm not sure what to do with myself anymore. Our schedules are getting busier. We all know that. So how do we do this in a way that makes this effective, that makes it easy, that works within our workflow? That's another big part of this EPA endeavor that's coming around. We've all been looking towards this holy grail of residency redesign. For better or worse, we train our residents in some respects much the same way as we have for the last 60 to 70 years, at least with time-based progression. And are there other ways to look at competency-based progression? I think that's really the holy grail that we haven't reached yet, but that's part of this for EPAs. So lastly, I want to come to the EPA pilot in surgery. Number of schools are participating in this, about 27 residency programs. Again, quick show of hands, how many of you are aware or know if your program is participating in the EPA pilot? Yeah. So there's a few, and it's a good number of the programs. This is actually developed by the board, but also done in collaboration with the Association of Program Directors in Surgery, the college, as well as the ACGME and the RRC for surgery. The pilot year is this coming academic year when it will be started. Right now, it's really just in the planning phases where they're getting IRBs and all of that just to get the study off the ground. So folks won't necessarily see this active for the coming months, but the goal is really to get this off the ground for the next academic year. As part of the pilot, then the goal will be to take back and see what are the practical limitations, the concerns, how much time did these things take. There are 5 cases or EPAs that are meant to be as the first part of the pilot, and here are the 5. Managing a patient with an inguinal hernia. And notice I said managing a patient. This is not how to perform an inguinal hernia. It's the whole package. Right? How do we generate a differential diagnosis? If their diagnosis is unclear, how do we do the appropriate workup or diagnostics? How do we consent the patient appropriately? How do we perform the technical aspects of the procedure? How do we deal with the complications that may come up after the procedure? How do we deal with aberrant anatomy or unexpected events during the operating room? Managing a patient with right lower quadrant pain, managing a patient with symptomatic cholelithiasis, doing a consult. So it's not just technical, it's also how do we do a consult with other healthcare providers, and then managing a patient with blunt or penetrating trauma. So these were the 5 EPAs that were selected by the organizing group, and will be the ones that will be evaluated over the coming academic year. So I think, stay tuned. Bottom line is stay tuned. These are things that I think are potentially very exciting. I think there's also, potential concerns about how they're going to be implemented, what kind of tools we're going to be able to use and have to do this feasibly and easily. But it's exciting. I will say, with regard to tools that are currently available now, there is one resource, a reference, that I would refer you to or recommend you to. And this comes from the AAMC. Now, just as a caveat, this is not specific to surgery. And in fact, it was really first described for medical students. Having said that, it's a really nice document for describing what the EPAs are, kind of the conceptual framework for the EPAs, how do they work. That diagram that I described, that I showed earlier, came from this document. And it really breaks it down. I'll warn you, it's a 100-page document. However, you don't have to get much past page 7 to really get the crux of it. Right there, they describe an EPA, how it relates to competencies, and actually ones that can be used for some of them can be used for junior general surgery training as well too. But this is online. If you just Google AAMC EPAs, you'll find it, and it's a PDF. Highly recommend it to anybody who's interested in learning more about this and how they're implemented. And we're looking forward to see in surgery how this is going to progress, and hopefully at next year's meeting we'll have more to report in that regard. So I think we'll stop there. And Matt, and Denise, are we wanting to come up then and for questions? All right, thank you.